Thank you, everyone, for the opportunity to present on a topic very near and dear to my heart here, which is peripheral arterial disease. And cardiovascular risk, not so peripheral. So I feel like nowadays the peripheral guys are the bastard childs, the redheaded stepchilds, compared to the valve cool, all the cool techniques you guys have. So let's see what we can do for peripheral arterial disease. So this is a topic I'm extremely passionate about. These are my disclosures in that I'm an internist. I'm one of the few cardiologists that actually still keeps my internal medicine up because I think it's important to understand and to relate to all aspects of vascular disease. As I like to say, we take care of you from your nose to your toes. And so the only way to do great work is to love what you do, and I have a great opportunity to work with some great people at Piedmont. And my objectives today are that PAD, or peripheral arterial disease, is very common. It's very easy to diagnose, and it has a very significant cardiovascular impact. Hopefully by the time you leave this lecture in 15, 20 minutes from now, you have an understanding that it's important that your patients have it. You just need to make that diagnosis and why we need to make that diagnosis. Talk a little bit about the current guidelines, most recently put out in 2016, and understand why you need to make this diagnosis, even if the patient is asymptomatic. I'm going to try to really stay on target here. So this is my favorite. This is Charles Dotter, the first, the father of angioplasty. This was done, if you remember, done actually in the SFA. A case done, I believe, back in 1966. And really, as I introduce myself to patients, I'm really just a plumber, and that's essentially why, and this is where it comes from. Understanding that we can make these patients much, much better with procedures that are minimally invasive. But the most important aspect, I think, about this is that this was an 80-year-old lady who refused a below-the-knee amputation when she presented with this dry gangrene of her foot. She came to Charlie Dotter, who then proceeded to basically daughter or crudely dilate her SFA focal stenosis in the adductor hiatus, and she went on to die 3 years later of congestive heart failure. So she didn't die of her legs, she died of cardiovascular risk, and that's why I bring this picture up here today. So just some symptoms to understand: there's intermittent claudication, which is essentially angina of the legs. There's pseudoclaudication, which is spinal stenosis. I see a fair amount. I probably order more lumbar spine MRIs than any other cardiologist because I get patients that are referred for leg pain. It's very classic pseudoclaudication. But then there's a number of other diseases that are out there, including what I found here at the VA in my prior job. This is FMD in a 73-year-old male presenting with leg pain as well. So there's another, you have to keep your differential wide and understand that not all leg pain is claudication. It also may be spinal stenosis and maybe some additional other non-common diagnoses. And then there's critical limb ischemia, and this is basically where the supply-demand mismatch gets so bad that you get ulceration or you get rest pain. The classic history point here is that patients dangled their leg off the edge of the bed at nighttime because the perfusion with gravity helps decrease their pain. And this is more of a chronic process, not an acute process. So I borrowed this from my mentor who trained me, Ivan Katserly, and this is a good way of looking at it, especially from the interventionalist. If you look at CAD versus PAD, acute coronary syndrome is very similar to critical limb ischemia. Stable angina is very similar to claudication. This is not a rush. No one dies from it. It is lifestyle limiting. However, why did I get in this? What do we as cardiologists tell patients to do? We tell them to walk. They come back and say, I can't walk, doc. It hurts too much. I can't go more than a half a block because my legs give out, or I have atypical symptoms, my weakness, or more commonly, I'm just getting older. And really what you're missing is that the patient has bad peripheral arterial disease. So in contrast to coronary, or very similar overlap to coronary artery disease, the major risk factors for PAD are really smoking, diabetes, and age. And when you put those three together, you have your highest risk patient population for amputation. If you look at the data across, if you look at hazard ratios, you can see that across the board that it's, again, diabetics who are getting older, male gender as well. But across the board, smoking is one of the highest risk factors for this disease entity. As we get older, the prevalence goes up across this board. As you get over the age of 70, the prevalence is much, much higher. You want to be looking for this as our patients are getting older. So where does a lot of this data come from? It comes from the Partners trial, which was published now many years ago in JAMA. This was done at 350 primary care sites, over 7,000 patients, and this was the foundation of the 2005 ACC Guidelines, but they essentially looked at all patients who were greater than the age of 70 or between the ages of 50 and 69 with any history of smoking or diabetes, And if I were to have you raise your hand, those are the majority of our patients, right? This is who we're seeing in the clinic. And if you look at PVD diagnosis as definition by an abnormal ankle brachial index or prior revascularization, almost 1 in 3, 29% of your patients have peripheral arterial disease. That's almost 1 in 3 who walk in your office that are coming in for your lipids or coming in for your cholesterol, coming in for your coronary disease or maybe your valvular disease, probably also have concomitant PAD. Now here's the scary part about that data. Almost 50% of the primary care providers in patients that had known peripheral vascular disease didn't know about it. They had no idea. And I always say you don't want to be that guy, all right? And the new diagnosis is about 52% of the time. So really, this is an underdiagnosed and under-recognized. This was something that was not taught to me. I had the privilege of training at UCSF for medicine. I got 0 lectures on peripheral arterial disease. And that's a tragedy. This was something that was thought to be just surgical realm, vascular realm, not something you should be talking about. Hopefully, by the end of this, you will see that this is actually our realm, and it's in a team approach that helps these patients do better. So why arterial disease ignored or perhaps maybe not picked up? And most of the time it's because it's asymptomatic. If you look at the data, most of the patients that have peripheral arterial disease are asymptomatic. So you may say, well, I don't care. I don't care if they're asymptomatic. If they don't have any leg pain, then who really matters? Well, let's look at the data here. The clinical impact, the mortality is 2 to 3 times higher than age and sex matched controls. Your 5-year mortality if you have PAD is 30%. That increases to 70% at 15 years, and 60 to 80% of patients with PAD have at least one vessel coronary disease. A quarter of them have carotid disease. And most importantly is that if you look at ABI across the board here, this is also a major risk factor for amputation. And let's look at quality of life. We just heard about heart failure, that perhaps maybe the greatest indicator of patient satisfaction is that they're out of the hospital. Well, let's look at quality of life in patients with peripheral arterial disease. Interestingly enough, critical limb ischemia patients, patients that have rest pain or ulcerations, have a quality of life equal to that of terminal cancer. These patients are absolutely miserable. And sometimes I wonder if that's why they're grumpy most of the time. They can be really challenging to deal with, and it's because their quality of life is very, very poor. And the interesting thing, if you look at Mary McDermott's data, the functional decline and the impairment that patients with PAD have is often asymptomatic, quote unquote, by traditional measures. But if you actually ask them, they say, you know, I'm just getting tired. I'm just getting weaker. I can't make it to the store that was 2 blocks away. Why? Well, I'm just getting older, doc. Really, why they can't get there is because they're having claudication. It's just presenting atypically. So I would ask how many patients have actually, or how many people in the room have actually done ABIs, but this is the traditional way of diagnosing peripheral vascular disease. And it's really very simple. You can train your MAs in the clinic to do this if you don't have a former vascular lab, and it's very simple with a handheld Doppler and a blood pressure cuff. And if your ABIs come back relatively normal, but your clinical suspicion is high enough, you can exercise these patients or do toe raises or any variety of exercise modalities to be able to then stress the legs and see, again, very similar to a stress test, see whether or not you're getting a supply-demand mismatch. And worst comes to worst, you can always go on Google and figure it out exactly, a good slide to look up on how to measure which numbers to use. ABI, if you look at the non-invasive measures, it's normal is about 1 to 1.3. There's a U-shaped curve here, and we'll talk a little bit about that, secondary to pseudo calcification of the intima, or the media, I should say. And really less than 0.9 is abnormal here. And this is why we care. If you look at abnormal ABI and mortality, look across the board here that if you have an abnormal ABI, your mortality goes up, your risk of heart disease goes up, your risk of stroke goes up, and across the board, your mortality is directly related mainly from cardiovascular events. So if you look at CVD mortality up there versus all-cause mortality, really looking at a U-shaped curve here. As you get more severe in the ABI, you get worse. As you get higher here, these are our patients with diabetes and end-stage renal disease that have calcification of their infrapopliteal vessels, so you can't compress their arteries, and so they get falsely elevated ABI. So once you get above a certain level, they have a very marked increase in cardiovascular and all-cause mortality as well. So remember, this U-shaped curve is critical. And so there's some new guidelines from the ACC, and I had the pleasure of working with Heather Gornick on the Vascular Medicine Journal, and these guidelines are well worth the 130-page read, but they actually put it pretty nicely in terms of summary statements that one can read through. And I'm going to go through a little bit about that. And the compare and contrast our new guidelines versus our old ones. The old ones were based on the partner trials where they basically said anyone who's in those age groups we talked about, those patients need ABIs. The new guidelines are saying anyone who has symptoms or physical exam findings consistent with PAD should get ABIs. Interestingly enough, they downgraded and they said anyone who has a increased risk for PAD, that's all our patients should get ABIs. I got a 2B recommendation. I probably would have personally increased that to a 2A recommendation, but we can leave some room for judgment. Here's your 5-year outcomes with PAD, and this is why I'm up here. All right, let's look at the outcomes here. 5-year outcomes. 20% have a non-fatal cardiovascular event. Mortality can be 15 to 30%, most of that being cardiovascular causes. So you ask why a cardiologist is interested in peripheral vascular disease. Well, eventually we like to see them before they get to this event, preferably before they come in with their non-STEMI. Let's look at the 5-year outcomes for patients with symptomatic disease. And this is going back to that slide earlier that we looked at in terms of patients that have stable angina of claudication. Most of these patients do pretty well who have stable claudication. They can be treated with medical therapy and exercise therapy, and that underscores the importance of understanding when patients are stable. Some go on for 10 to maybe 30%, get worse in claudication, understanding that some of these present with atypical symptoms. And thankfully, only 1 to 2% go on to develop ulcers or rest pain. However, when we're getting to this point, these patients are extremely, extremely ill. And part of that, if you look at CLI, underscoring how ill patients with critical limb ischemia are, look at your cardiovascular death at 1 year. So I showed you 5-year data. This is 1-year outcomes. 1 out of every 4 will be dead by 1 year. And they're dying from cardiovascular causes. So Heather Gornick at the Cleveland Clinic and gave this talk many years ago and put these together, and I borrowed this from her looking at a kind of a triple approach. Now, I used to work for the government where quadruple P meant something else, piss poor pathetic planning. Here, we're talking about PAD being prevention, protection, and plumbing for your patients with PAD. All patients who have peripheral arterial disease need prevention, they need protection, and those patients who have symptoms should go on to look at their plumbing. And so this is an approach that I use on a routine basis. I talk to my patients about it. I put it in my EPIC notes if you've read them, for those of you from Piedmont. And the key thing is protection and really foot care. How many people in this room have their diabetic patients take off their socks and shoes when they come in to see in the office? That's remarkable that it's actually this high. I usually ask that question at grand rounds, and maybe one person open, maybe 2 people. Very, very few of us were here. We got 5 minutes to see the patient, going to go in, examine their heart, see how they're doing. We're not going to look at their socks and shoes. Sometimes when you take off their socks and shoes, you find dry gangrene. Sometimes you find poorly controlled tinea, which is a major risk factor for infection. And this is the importance to really talk to your patients for 30 seconds about meticulous foot and nail care, daily foot inspection, and all your patients who have diabetes. All patients need to be seen by a podiatry or in consultation with a diabetic specialist that's really going to look for neuropathy and spend that time going over the foot care. That cannot be underscored. And prevention. So most of us in cardiology would probably, maybe some of us would actually take off the socks and shoes, as you notice, but look at this. This is what we do every single day. We talk to patients about smoking cessation. We talk about antiplatelet therapy. We talk about lipid-lowering therapy, control their blood pressure. I'll talk a little bit about ACE inhibitors and talk a little bit about glycemic index. Well, smoking cessation is a no-brainer. All of our patients need to be discussed with smoking cessation when it comes to the PAD. Smoking cessation decreases your amputation, makes you live longer, people feel better, improves your ability to walk. This is not telling anyone something they don't know. And across the board, our new guidelines, again, recommend that all patients with PAD be advised to quit smoking and then whatever it takes to get them to quit smoking. Be it Chantix, be it Wellbutrin, be it the Georgia No Quit line or a help stop smoking line, whatever it takes. It's a no-brainer area. What about antiplatelet therapy? I always show a willow tree, which we see a lot in the South because that's where aspirin comes from, the bark of a willow tree. In meta-analysis of all antiplatelet therapy across the board, aspirin's been shown, doesn't matter what PAD subtypes you have, aspirin is beneficial in reduction in vascular event rates. All patients who have PAD have CAD, therefore need to be placed on aspirin. They can also be placed on Plavix, especially nowadays with the cost being generic, and that comes from the Capri trial, basically showing a benefit of clopidogrel over aspirin in symptomatic PAD patients with respect to cardiovascular risk reduction. So either one, doesn't matter, whatever you feel comfortable with. And so here's some updated statements. I get asked this a lot. What should patients be on who have peripheral arterial disease? And I think if you look at antiplatelet therapy with either aspirin or Plavix is recommended, that's a class 1. It's a 2A for patients with asymptomatic with PAD, that they be on antiplatelet therapy to reduce MI, stroke, or vascular death. And then you get into this area of 2B recommendations. Dual antiplatelet therapy falls in there. That really you don't need to have your patients on dual antiplatelet therapy. Now, many of our patients are because they have coronary stents, but this is another area that people ask me, say, you know, do you need to, if you have bad SFA disease, be on both aspirin and Plavix? I say really just aspirin or Plavix alone. Let's not increase their risk of bleeding because we know that worsens their outcome. Interestingly enough, if you look at the new guidelines, people do ask me about Vorapaxar. It got a 2B recommendation because even though it had a positive effect in the trial, which I believe is TIMI 51B, it was the cost issue came up largely, and the outcome is questionable. So it's really uncertain at this time what to do with that drug. You should not use Coumadin or NOACs for primary prevention of adverse cardiovascular events unless your patient's already on it for another reason. That's why we try to minimize the risk of bleeding in these patients, and adding just more on top of it is just going to increase it. If you look at statins, this is what we do. They basically improve claudication in single-center trials. This has been the holy grail. They actually slow functional rate of functional decline upon patients with PAD. Interestingly enough, if you talk about pleiotropic effects of PAD, it does improve patency of infrainguinal bypass grafts. Don't ask me how. It also decreases your risk of perioperative complications in the patients undergoing vascular surgery. So statins across the board should be on board all your patients with PAD. This is the heart protection study showing, again, right across the board that patients who are on simvastatin in this case do better. And this is interesting enough that statins, again, going to that pleiotropic effect, this was done a little bit earlier. Statins actually made you walk further. So the leg pain that everyone complains about may be something else. Simvastatin versus placebo actually had increased walking distance. A lot of people don't realize that. Which one to use doesn't really matter. What level you get to, the old guidelines said less than 100. New guidelines are just, it's indicated, and we can argue about that another time. Which drugs to use for blood pressure? Antihypertensives should be recommended, and controlling blood pressure to reduce risk in MI and heart failure. The key thing is some of you, including myself, were taught that beta blockers were contraindicated in PAD. That is a myth. That was an old school mentality that is completely false. And so beta blockers are very effective, and they are not contraindicated in patients with PAD. What about ACE inhibitors and ARBs? We have pretty substantial data that shows that ACE inhibitors and ARBs are very beneficial in patients with PAD, not only for the reduction of cardiovascular events, but also, interestingly enough, they actually do increase your ability to walk as well. So diabetes, the old guidelines basically said use podiatry, get a diabetes team on board. The new guidelines are basically saying that you should talk about foot care, which we already talked about, and then also should be coordinated by partners of the healthcare team. Personally, myself, I feel like it used to be insulin, metformin, glyburide, glipizide. Now it's about 50 other drugs. I just refer to the endocrine team because I can't keep them all straight. Prevention across the board, A1C should be controlled as best as can be controlled using multidisciplinary team. And as per the patients that go on of the prevention and the protection, the plumbing aspects for those patients who have symptomatic is beyond this talk, but there's medical therapy, there's exercise therapy, there's endovascular therapy, and there's surgical options. Really, it doesn't matter what you choose at this level. What matters is that all patients, the foundation of care, patients with peripheral arterial disease is medical. This is what we do as internists, what we do as cardiologists. It's important that our patients be on guideline-directed medical therapy. I always tell patients, if I fix your leg and you drop dead of a heart attack because I didn't have you on the right medicines, did I do you any favors? The answer is no. And so is there some data to say that what I'm saying actually has some outcomes? Well, if you look at Guideline Concordance, it actually does prevent amputation, and this is an article from JVS. And more importantly, my friend Aaron Armstrong at the VA in Colorado, where I did my training, basically showed that Guideline Concordance saves lives. If you have your patients on aspirin, Smoking absence, I don't know how they got smoking absence in 71% of their patient population, but it's pretty impressive. And they were on an ACE inhibitor and a statin. Look at the difference in these guidelines. Look at the difference in terms of mortality. If you get these patients on the right drugs, they live longer. So how should we best treat PAD? It's a team approach. This is not one person. This is a multidisciplinary group, and it's, credit to Heather Gornick and the ACC team for really showing this. If you look at the outcome, if you look at the bottom line, is that it requires teamwork. It requires everybody, nurses, nurse practitioners, lipid clinics, diabetes clinics, infectious disease, podiatry. One person can't do all of this. We're just one cog in a large wheel, but your patients need to make that diagnosis first so they can get that teamwork and get that care together, coordinating them so that at the end of the day they can walk further, but also they can get the right medical care so that they're going to live longer. And so in conclusion, PAD is very common. Patients with PAD don't die from their legs. They die from cardiovascular complications. And prevention, protection, and plumbing, remember that. And multidisciplinary teams are the key for everything here. I think if there's one pattern that I've seen throughout this morning sessions and throughout this conference is that really it's all about teamwork, and it's about working together to optimize not only your patient and your patient's outcome, but also your healthcare system's outcome. And so the question is, who's on your team? And with that, I'll say thanks so much.